Here's our clinical pathway for this session. We'll start with the diagnostic workup, move into benign and premalignant lesions, touch on malignant soft tissue tumors, and then spend the bulk of our time on melanoma, specifically risks and staging, wrapping up with surgical and medical algorithms. Starting off with Section 1, Diagnostic Workup, Skin Lesions versus Soft Tissue Masses. Let's draw a hard line right out of the gate between these two approaches. For skin lesions, an excisional biopsy is your absolute gold standard. You definitely want to avoid superficial shave biopsies here, simply because preserving that Breslow depth is absolutely crucial for accurate staging down the line. Now, for soft tissue masses, it's a totally different story. Start with an MRI. If the mass is under 3 centimeters, go ahead and excise it. But if it's over 3 centimeters, an incisional biopsy is the definitive rule. You've got to lock that difference in. Okay, let's anchor the ABCDEs of the physical exam. Look at how stark the visual contrast is between an irregularly colored, asymmetric melanoma with those jagged, blurred borders compared directly to a uniformly colored, perfectly circumscribed benign nevus. Just remember, any pigmented lesion showing asymmetry, irregular borders, color variation, a diameter over 6 millimeters, or evolution, well, that mandates a full-thickness biopsy. No exceptions. Moving rapidly to Section 2, benign and premalignant lesions. We'll hit the high-yield associations you need to know. This is densely packed with high-yield associations. For seborrheic keratosis, always watch for the lesser Trellat sign. That's a sudden, explosive breakout of multiple lesions warning you of an underlying paraneoplastic syndrome. Actinic keratosis? Those are major premalignant threats. Up to 20% of these will actually progress to squamous cell carcinoma. For nevi, the key rule of thumb is that junctional nevi rarely develop after age 40. So if you see a new one pop up, treat it as highly suspicious for melanoma risk. And finally, lipomas. Sure, they're literally the most common human neoplasm, but their malignant potential is incredibly low. We're talking less than 1%. Section 3, Malignant Soft Tissue Tumors. Let's look at aggressive local growth. When we're talking about dermatofibrosarcoma protuberans, or DFSSP, the key word is infiltrative. This tumor is locally aggressive. To prevent a devastating recurrence, excision absolutely mandates strict 2 to 3 centimeter margins to achieve an R0 resection. And keep in mind, your independent predictors for recurrence here are the primary tumor depth and microscopic margin positivity. All right, Section 4, our deep dive, melanoma risks and staging. This happens to be the 5th most common cancer. Let's build out our understanding of genetic risk by explicitly defining FAM syndrome. That's familial atypical multiple mole melanoma. This diagnosis requires a history of melanoma in a first or second degree relative, having over 50 nevi, and a very specific histology. Interestingly, about 40% of these families actually carry P16 germline mutations. And here is a massive clinical pearl. These patients require regular eye exams because their risk for ocular melanoma is drastically increased. Do not miss that detail.
So why does all this staging matter? The crucial point is right here in the numbers. Breslow thickness, which, remember, is the physical depth of the primary tumor, is the single most important prognostic factor. Think about this. If a tumor is less than 1 millimeter thick, the 10-year survival is an excellent 92%. But the moment that lesion crosses the 4 millimeter mark, that survival rate literally plummets to just 50%. It becomes a coin flip.
Take a close look at this presentation on the thigh demonstrating satellitosis. The presence of these in-transit metastases and satellite lesions immediately signifies a dire prognosis. It's a massive red flag indicating a huge risk for both local recurrence and distant spread. Beyond just Breslow depth, you need to quickly identify other independent negative prognostic factors. Immediately look for the presence of ulceration and a high mitotic rate, because those will automatically upgrade your TNM staging. Older age and male gender are also working against the patient, as well as a location on the Bands regions. That stands for back, posterolateral arm, neck, or scalp. And finally, regional node metastasis is absolutely devastating, dropping that 5-year survival rate down into the 40 to 70% range. Let's translate this into action with Section 5, Melanoma Surgical and Medical Algorithms, specifically focusing on excision margins and lymph node management. You really need to memorize these parameters. Wide local excision is your primary treatment, and your margin depends entirely on that Breslow thickness. Melanoma in situ gets a strict 5 millimeter margin. Thin lesions, meaning anything under 1.0 millimeter, get a 1 centimeter margin.
And the heavily tested rule of thumb is that intermediate and thick lesions, anything over 1.0 millimeter, require a definitive 2 centimeter margin. This is a hard standard validated by multiple randomized controlled trials. Following this therapeutic decision algorithm, you can see exactly when you need to escalate care. The big trigger point is this: intermediate thickness lesions, or thin lesions that happen to show ulceration or elevated mitoses, immediately trigger the need for a sentinel lymph node biopsy. Let's talk about that sentinel lymph node biopsy, or SLNB. This procedure has completely replaced the outdated elective lymph node dissection. Why? Because the histology of the sentinel node accurately reflects the entire nodal basin. Actually, a negative sentinel node has a false negative rate of less than 1%, which is incredible. The landmark MSLTI trial proved that SLNB is highly beneficial specifically for intermediate thickness melanomas, meaning those between 1.2 and 3.5 millimeters. And remember, finding metastatic disease within that sentinel node is the single most important prognostic factor for overall survival. Finally, let's look at how medical management has evolved. Historical histological subtypes are pretty much out, and molecular classification is fully in. For unresectable extremity in-transit melanoma, we use isolated limb perfusion, or infusion, to deliver regional chemotherapy. Systemically, immunotherapy is the standard now, using drugs like ipilimumab, which targets CTLA-4, and pembrolizumab, which targets PD-1. You also absolutely must test for BRAF and NRAS mutations. If you find V600 BRAF mutations, those patients are prime candidates for targeted molecular inhibitors like vemurafenib and dabrafenib. I'm going to leave you with this clinical scenario to test your retention. A patient presents with a 2.5 millimeter Breslow depth melanoma with no ulceration. Based on the algorithms, what's your mandatory surgical margin and your next step in nodal staging? Well, a 2.5 millimeter depth requires a 2 centimeter surgical margin, and since it's an intermediate thickness lesion, it mandates a sentinel lymph node biopsy. Master those parameters, and you master the baseline of care for this entire chapter. But as molecular classifications rapidly evolve, ask yourself this: how long until targeted immunotherapies completely replace the need for wide surgical margins altogether? Definitely something to think about. Thanks for joining this explainer, and keep studying.